Good morning, everyone. Thank you for the invitation to present today. Um, uh, I am in a difficult position to be between you and your lunch, so I share that. I'm very food-oriented, so I will stop at. I'll give the thank you slide on time. Uh, yes, I'm a professor at the Icahn School of Medicine at Mount Sinai in New York City. And I am 3 days after my 22nd anniversary at Mount Sinai when I actually came. I was asked immediately to create a clinic for the responders, and those are the rescue and recovery workers and volunteers, as Dr. Cohn appropriately reminded, that were part of the disaster response. And that excluded the firefighters after the first year. So initially we saw firefighters, then we mostly stopped seeing them. So in terms of disclosures, I'm practically 100% dedicated to the World Trade Center. I've always been. And I have some grant funding as an investigator, mostly practically all of them from the National Institute for Occupational Safety and Health. And we are always required to indicate that any views presented in these lectures do not represent in any way those of the World Trade Center Health Program, the Center for Disease Control, the NIOSH, or even Mount Sinai. So there you go. But that's good, because at least it gives me the opportunity to communicate, as I have with Dr. Juarez and Maneke, about my personal views. That's totally what they are. So about the World Trade Center General Responders Cohort, as I say, includes workers and volunteers. And being an occupational pulmonologist, of course, I have a little bit of a focus on the lower airway diseases of these workers. As many of you are aware, more than 50,000, and the number is all subject of controversies, rescue and recovery workers and volunteers were exposed to a very complex mixture that really nobody knows what it was made of. Essentially, every opportunity to characterize the persistent exposures at the site was missed. And that in and of itself is a chapter. I won't belabor the point, but nothing is known about it that is of real substance. So several non-malignant chronic diseases have been reported, including lower airway diseases, that just for those that are non-pulmonologists, probably majority, are diseases of the airway below the vocal cords. Easy. So when it's upper airway disease, it's above the vocal cords. So one of the challenges that I faced when I came to the clinic was that essentially was a picture like that, a very colorful scene everywhere, dots all over the place, trying to make a sense of a multitude of symptoms. And it was a good fortune that I was already 10 years post my clinical training so that I could face this. And I was given a month because I was on philanthropic funding. So I was given a month to essentially create protocols for the investigation of the lower airway diseases. We took some from the literature, like this one for gastroesophageal reflux disease. That was fine. It was good. It applied to our population. We created in-house with the Department of Otolaryngology a protocol for evaluation of rhinosinusitis, pharyngitis, and laryngitis, the entire upper airway. All of those were published. And eventually we came up with some sense of the main World Trade Center related health effects. And they are listed here. I won't belabor the point, but those were the 5 major groups of diseases. And as you can see, it's all trying to make some sense of a very scattered set of points. Most of the individuals had comorbidities, so that was reinforced. And these conditions, these diseases are mutually worsening. In other words, upper airway makes lower airway more severe. Reflux is supposed to also make it. And then add to that mental health, and you get a very complex patient to manage. The investigation of these chronic lower airway diseases began very early. In October, as early as 2001, October 2001, there were individuals complaining about symptoms. And as I said, there was a variety of disorders. And we were trying to obtain objective measures of lung function in order to support those diagnoses. So spirometry was our main tool, and as you can see here, and a little bit similar to some of what has been mentioned, this pointer is not working for me. The reduction in the forced vital capacity when the spirometry was abnormal was by far the most common spirometric abnormality and in the lung function measurement. And the problem with that is that it is a very non-specific finding that is also related to obesity. So you can only imagine the controversies and the claims to discredit the work that we were trying to do. Just to complement a little bit the excellent presentation from Dr. Cohn, so how we were set up at Mount Sinai with the General Responders Cohort. Essentially, we had two arms. One was the worker and volunteer medical monitoring program. The two medical co-directors, whom I wanted to mention because they really try to organize this massive operation. They are not with us anymore. This was funded by NIOSH, and the screening began in July of 2002 officially. So, and then it was supposed to be followed by longitudinal health surveillance with evaluations every 12 to 18 months. Initially it was every 18 months, now it's supposed to be every 12 months. But we capture people when they can, when they show up, and that's how it is. The intervals are highly variable. So this is the data gathering part of the operation. I'm sorry, I went backwards. And it needs to be stressed that Mount Sinai is by far the largest, but is only one of 5 occupational, most of them occupational health clinics in the New York, New Jersey area. They form a consortium that exists to this day. So it's 5 centers that in New York, New Jersey, and there was an outreach unit helping to establish the cohort, reaching out to labor unions, to community groups, but because it was an occupational cohort, labor unions played a very a strong role in helping us create this cohort. So in this publication from Dr. Herbert, there are some of these details that I will just cover very superficially. It was an executive steering committee with representatives from each of the consortium clinics, from labor unions, employers, technical experts from relevant fields, and there was an advisory council where we tried to engage stakeholders and responder organizations to set the direction of much of this work. So on the other side, and that's the one where I came to help organize, was what we call the treatment program. I'm sorry for the jargon, but that's exactly how we call it. And essentially it's individualized diagnosis and treatment. Whereas in the screening and monitoring, there is data gathering. On our side, there was diagnosis and treatment. And that began, as you can see here, in January 2003. That's 1 month after I joined Mount Sinai. I was given only 30 days to set everything up. So, and the reason was because there were many abnormalities and symptoms that, reported by these individuals that needed to be addressed. And people tend not to go to doctor to be screened or monitored. They want to be diagnosed and treated. So the reality, the need was identified very soon, and with philanthropic funding that kept changing every year, a year and a half, we started. Only until November of 2006, where our side of the program, the treatment program, became funded by federally. So the way it developed is you take two departments at Mount Sinai. Our department was called at that time Community and Preventive Medicine. That was occupational medicine, yes. We are called something else right now. And the Department of Psychiatry created the data gathering side of the program with the medical screening and monitoring. And then in very short sequence, less than 6 months, they created the treatment programs, both for physical health and for mental health. So we actually, at the beginning in 2002-03, each part of this program had a different funding source. So eventually, the functions were merged. But the responsibilities remain identifiable. So there is a data gathering function, there is a diagnosis and treatment function, and there is a mental health and a physical health side of it, 2 by 2. All right. So the monitoring program, essentially, but to go very quickly, is, it screening includes a variety of questionnaires, either self and or interviewer administered, medical, psychological, and exposure questionnaires, physical examination, spirometry, which is a basic lung function measurement device, and chest radiograph, and a routine laboratory test. There was nothing extraordinary to what was being obtained, chemistry, urine tests, blood counts, lipid panel, chemistry panel too. And then, as I said, the subsequent monitoring examinations were scheduled every 12 to 18 months. On the health treatment side, we had basically two arms. One was a physician arm with clinical care, diagnosis and treatment, and social services. And we coordinated with the mental health group in the treatment side to provide adequate services to our patients. We were not supposed to be the primary care providers for, occupational physicians are not primary care doctors. But we certainly had a group that had the qualifications, so we wouldn't miss certain needs, and we certainly didn't miss those needs. And we used an extensive network of collaborating health institutions in the city to refer patients appropriately and work with primary care doctors on the management of, if somebody presents with rhinitis because of exposure to smoke, that it really takes a second place if that person has chest pain from angina and needs to be appropriately treated for cardiac disease. So just to give you an example of that. Social work was an extremely important arm of an extremely successful part of our treatment. I offered to the organizers of the MauiWES study to place them in contact with the social worker extraordinaire that worked with us and that figured it all out so it was like a triad. I was in the medical side, there was a counterpart in psychiatrist, and there was the social worker, and one day I can, put you in contact with all of them. So the variety of services that the social workers provided is beyond description. We have a publication somewhere in the Journal of Occupational Environmental Medicine about it, and I can make it available to those who may be interested. We actually don't have that person with us anymore. She moved to another state and to something better and closer to her heart. So, but the range of issues that they were dealing with ran the gamut. I listed some of them there: domestic violence, substance abuse, housing issues, English as a second language. We had a high proportion of undocumented immigrants, so immigration legal service referrals, support during and after surgical procedures, hospice care, you name it, all of that we did. So a few years down the road, under the presidency of Obama, there was a congressionally mandated program, the World Trade Center Health Program, administered by NIOSH, and it's essentially a partial health insurance for responders and survivors. Survivors we call the community reoccupants. In World Trade Center lingo, that's what that word means. And responders is rescue and recovery workers and volunteers. So it is administered through a number of clinical centers of excellence, CCEs we call them, and a nationwide provider network. And it covers a fairly wide number of diagnoses that are in the lingo of the program, certified to have something to do with exposure. Whether that's questionable or not is beyond this discussion. The World Trade Center Health Program has also a research arm under which I'm funded, as I mentioned at the beginning. There are data centers, there are grants, contracts, cooperative agreements. Dr. Cohn referred to the work of the registry. It's also part of that. And not to be confused, but fortunately or unfortunately, not completely disconnected from much of what I've said, the Department of Justice has what is called the 9/11 Victim Compensation Fund, which awards financial awards based on those certified diagnoses. And that creates a particular dynamic to this program that, again, I will be happy to discuss with those that may be interested. I will go very quickly on our investigations on lower airway diseases, although that's most of what I do, really. And just to say that right from the beginning, we thought that the smallest branches of the airways, which this is a normal airway and this is an inflamed one, were the ones that may have been affected by the smaller size particles generated by the smoke and dust exposures at the disaster site. So at that time, I had established a collaboration with the radiologists, and I told them, why don't you come up with a, semi-quantitative, indicator of the abnormalities that are seen in the chest CT scans. And just for reference, a normal CT scan and a cut at the end are usually done at the end of inhalation, and they usually have that appearance. And at the end of exhalation is supposed to increase in density very little, and you probably won't be able to appreciate that here, but there is a slight whiteness on the right-hand side, but very homogeneously distributed. And in the World Trade Center workers, we often saw this pattern with a checkerboard on the right-hand side that was clearly completely different, and is usually an indication of damage of those smaller airways that I just mentioned before. So we kept moving to more quantitative methods so that we would have objective data that we could report in the scientific literature, and went to semi-quantitative systems and have the radiologists complete these. This was already for research purposes, so they have the scoring sheet that they could use. And we took 1,500 individuals that had chest CT scans, and as you can see, there are some abnormalities that they were there that they were not trivial. More than 20% had pleural disease that could be possibly related to asbestos exposure, but we also determined that most of those exposures probably took place before the World Trade Center disaster, given the timing of the chest CT scans and the time that it takes to develop those changes upon exposure. So that's very important, because many of these workers that came to the World Trade Center disaster site were not rookies. They actually they had a mean age of about 40, which tells you that many of them had easily 15 or 10 years of work exposure before. And if you ever have seen pictures of how the disaster site looked, you could imagine imagine that no rookie would be have much appetite to get into that. It was a very strange and very difficult area to work in. So moving on a few years later, again with research funding through the World Trade Center Health Program, we started working with engineers that do visual analysis of the chest CT scans, and they do reconstructions in different projections and produce measurements of different structures that we can use for research. And again, to try to bring objective representation to abnormalities that might be very subtle and that many radiologists in the community could easily miss or completely dismiss. So I work with two engineers, one based in Boston, he's still working with me, and another one at Cornell University, an upstate university. And they essentially produce a lot of measurements for many of the chest CT scans that we had in our archive. And just to give you an idea of how these things could look like, I show here an airway, and they actually try to get the thickness of the wall, because that would be an indication of inflammation in the airway. And that was called the wall area percent, that you can see it there. And we saw it in this publication that I will gloss over very superficially, that it was associated and correlated in adjusted analysis with accelerating decline in lung function. So we also noticed that obesity was a very strong predictor in those models, although that was not our primary predictor. And then we actually started examining the role of obesity. A fact that is seldom mentioned about these cohorts, the occupational cohorts, is that the prevalence of overweight and obesity exceeds that of the U.S. general population. And that comes out as a complete shocker to everybody that I tell them, and I don't know why but this cohort is actually about 82% overweight or obese by the usual BMI indicators. And we could determine in this study that the more overweight or obese the person, the higher the body mass index is, the higher the wall area percent is, indicating inflammation. And there is this interaction between obesity and inflammation, which is increasingly recognized, and we could demonstrate in this cohort precisely because of those measurements that we were using. So I'll skip over that, but it was the other thing that we have been concerned, having data on spirometry going back now for 20 years, is that although the majority of the individuals were in these green line of a very mild age-related decline in lung function, we had subgroups within the cohort that were really crashing very fast, but we also have some that seem to be recovering lung function. Which makes sense after an injury, in that at least that's a maybe a speculation on my part, and it's a hypothesis right now for the grants in which we are involved, to try to see if what is the difference between these subgroups, what types of injuries do they have, and try to use the tools of quantitative CT to actually answer those questions, if at all. One of the major concerns that we have had is with these low forced vital capacities parametric patterns that I referred to before. That is, it is a very interesting topic, and that 20 years ago was dismissed completely as a byproduct of obesity, and it turns out that there's more to it than that. And we could tell that it was actually associated with the exposures, and that it was associated with this wall area percent or proximal airway inflammation indicator that I mentioned a minute ago. So And then we went on to actually, now that we have 20 years of follow-up with this cohort and that we have spirometric data going back that far, that if we use a spirometric definition of chronic obstructive pulmonary disease or COPD, that there was actually an association with the exposures. And we also did some work with Dr. Cohn in the registry using different type of data, self-reported diagnosis of COPD, and we found something similar. So we have to really watch and follow this cohort to really figure out how to intervene. By the way, talking about intervention, these cohorts were not heavily smoking. They were in 2001, the current smoking prevalence was about 22%, which was what was current in the state of New York. And right now, they stand at about 8% through smoking cessation efforts that have been conducted at multiple levels, including individualized treatment in our program. So I won't belabor some of the issues of longitudinal follow-up because it's a little bit time-consuming. Many people may be familiar that whenever you have these clouds of data, you try to use techniques like cluster analysis to try to figure out a little bit what the pattern is, and I keep going back to that. And we just recently published a cluster analysis of these lower airway disorders using data, demographic areas, smoking data, lung function data, and the quantitative CT data that I just mentioned a moment ago. And again, I won't belabor the point, but we actually were able to discern certain patterns, people who were healthier, people who were have fit, for example, in this first column, various patterns of COPD. And the low FVC group actually broke down into two subgroups, and we are right now trying to expand these studies and also the measurements that we use for that. Everybody usually asks me, but did you look at the lung? Yes, we did. There are some mineralogic studies that we were doing. We had the fortune of being able to find a laboratory because there are very few laboratories that do this work. And actually, this was done by a laboratory in France, just to tell you that it's not easy to get a laboratory that will do these studies. And there are some methodological limitations to how this is done, and that's why I won't expand or belabor this point, but we actually have some of those. I'll skip this one. And Dr. Juarez asked me, one of our publications was trying to establish a connection between post-traumatic stress disorder and objective measures of lung function. So, because ever since Freud, it has been proposed that asthma and anxiety disorders, really have more in common than one would accept. So the study was published in 2016 without funding. So I just, once we failed with a grant with my collaborator in Pittsburgh, I said, in that preliminary data that we put there, I think that there's something. And we actually showed that probable PTSD was associated with bronchodilator response, which is one of the characteristics of asthma, even after we excluded smoking completely. And also when we did follow-up, we could tell that people who had more chronic forms of COPD, of PTSD in this, have even a higher, a larger increase in the risk of having asthma diagnosed. So again, patterns. That's how it looked. It still looks like that. And all what I can say in these cohorts, we have a convergence of a number of pro-inflammatory pathways, that there are occupational exposures, both World Trade Center related and unrelated, tobacco smoking, which are decreasing, have precipitously decreased, highly prevalent overweight and obesity, and also increasingly prevalent overweight and obesity, because that's what happened with aging, and highly prevalent physical and psychological comorbidities that, as I just demonstrated, probably has an effect on respiratory health. And so, unfortunately, I won't have much time to, because I'm hitting the 15-second mark. We have a number of challenges. These are self-reported World Trade Center related and unrelated exposures and symptoms, and we do a lot of research that compares more versus less WTC exposed when the exposures were not measured. So we have a variety of biases, confounding, time-varying variables. Ours is an open cohort. People can join today. There are issues of cohort attrition, and there is a major issue with the fact that there are financially rewarded symptoms and diagnosis. And that creates a tremendous challenge in research. That's the view that nobody would like me to say, but that's exactly what it is. So I'll skip all of that, and just to say that I really have a huge number of collaborators, because clinical research is like that. Usually people take time from their busy schedules to try to do things. And they are listed here, and I won't go over them. They are all a little bit over, the United States, and many of them at Mount Sinai.